We're going to be doing a video for the palpation of the lower extremity ligaments, and we're going to be starting off with the inguinal ligament. So we have our person in supine. I'm going to ask her to border. So she's going to take her left hand and put the ulnar border across her pubic bones so that I'm going to stay above them. I'm going to be starting by finding the iliac crest. So I'm going to follow along until I find the anterior superior iliac spine, which is one attachment for the inguinal ligament. And then I'm going to go on either side of it or just on the top of it and gently palpate back and forth over top of this ligament, and it's going to take me down to the pubic tubercle of the pubis. So in between the ASIS and the pubic tubercle here, this is our inguinal ligament, which is a main attachment for our abdominal muscles in the internal and external abdominal oblique. And then we're going to be turning our partner over so that we can access posterior ligaments of the pelvis. Next, we're going to be showing as much as we can of the ilio lumbar ligament. The ilio lumbar ligament is going to be extremely challenging. It's not going to be an accurate palpation of it, but we're just going to showcase approximately where it is. So what I'm going to be doing is following the ilium posteriorly until I find the PSIS, posterior superior iliac spine. And then I'm going to go central and find the spinous process of lumbar 5, and above that, the spinous process of lumbar 4. And then I'm going to travel lateral. This is not going to be a direct palpation of them, but what I'm trying to showcase is that iliolumbar ligament attaches from the anterior internal surface of the ilium and goes towards the direction of the TVP transverse process of L4 and L5. So you're not going to be able to strum it directly, but I'm just showcasing where it would be. I'm going to curl my fingers to the APSIS, posterior superior, and then I'm just going to move on an oblique angle, trying to kind of transverse strum, in quotations, them. You're not going to feel it, like I said, you're going through a lot of back tissue and thoracolumbar fascia, but it's just an approximate location of where this iliolumbar ligament is. Next, we're going to be locating sacrotuberous ligament. I'm going to start by finding the PSIS, posterior superior iliac spine. I'm going to move directly down along the ilium until I drop off the ilium into the greater sciatic notch, which is approximately here. So I have PSIS palpating down posterior inferior iliac spine, and then we drop into the greater sciatic notch. Medial to that is going to be that lateral edge of the sacrum. A portion of that is the lateral sacral crest, and I want to find the last part of sacrum before it starts heading central towards coccyx. So at this location here is the lower attachment along that lateral sacrum and the corner. With my other hand, I'm going to use the palm and I'm going to push up into the hamstring attachment and then get a little more specific with my fingertips, finding the ischial tuberosity, which is right in this location. So this ligament is going between my two hands, somewhat on an oblique angle like so. And it's going to blend into that posterior sacroiliac ligament. So I'm going to strum this, go back and forth. This is a major glute max attachment, gluteus maximus. So you are going to be palpating a little bit through glute max as you go all along the sacrotuberous ligament. It's quite taut, it's quite easy to palpate, even though you might just be feeling a little bit of gluteus maximus in the process of it. So that's going to conclude our sacrotuberous ligament. We're going to be palpating the posterior sacroiliac ligament next. And what I'm basically going to be trying to do is landmark where the ilium and the sacrum are making contact together at their auricular surfaces. Now you won't be able to actually contact the auricular surface, but we're going to try to hook our fingers as close as we can to the joint line and then the ligament that crosses it. Right in this location here, I have the posterior superior iliac spine, PSIS, and I'm going to travel down until I feel that sciatic notch, greater sciatic notch, and go up to the PIIS. So posterior superior and posterior inferior iliac spine. I'm going to hook my fingers along this edge of bone, trying to kind of grab onto it. And this is my fingers trying to sink a little bit into the sacroiliac joint. So the sacrum kind of being in this location here and the ilium attaching up against it. Now there's a lot of dense tissue in here, being sacroiliac ligament plus a few others all blending together. So if you were to strum superior inferior while you're in this kind of hooked manner, you might be getting a portion of that ligamentous tissue. There's a couple ways to try to create movement. Now I'm going to say create movement kind of with quotations because it just depends on how much movement you believe is happening at this SI ligament and can we actually feel it. So two ways to go about this. I'm going to hook my finger on the ilium up against the sacrum, and I'm going to use her femur as a kind of fulcrum and a point of pressure. So as I fully internally rotate the femur into the acetabulum, the next thing that's going to start to move is pressure into the ilium and sacrum as the pelvis starts to move. So a theory is that as you force the neck of the femur into the acetabulum, it'll pull on the ilium, which then pulls a little bit on the sacrum, creating a slight bit of movement here at the sacroiliac joint. The second way that you might be able to create a little bit of motion, again, minor, is to go underneath the knee, picking up the leg, and as you fully extend the acetabulofemoral joint, that's going to transfer a little bit of energy into the ilium or the innominate bone as a whole, which will start to anteriorly rotate it a little bit. So what I'm going to do is again go back, find PSIS, hook my fingers into that joint space, and then try to lift the femur into extension as much as I can, which will then create, again in quotations, a little bit, a couple millimeters of movement, which we will most likely not be able to perceive that motion anyways. So again, just along in this area, traveling back and forth is the posterior sacroiliac ligament. And the last ligament of the pelvis that we're going to be palpating is sacrospinous ligament. So what I'm going to first start off with is trying to find both ischial spine and then the sacrum. So the first thing I'm going to look for is the ischial tuberosity. So we can use the palm of the hand and push in kind of right where the hamstrings are attaching up to the bottom of the gluteals. I've found the ischial tuberosity, I have a pincher's grasp on it. Well, this time what we're going to do is actually go on the medial aspect of it. So when you find the ischial tuberosity, you're going to hook your fingers to the internal surface of the ischial tuberosity, like so. And then I'm going to be moving directly superior towards the spine. As I do so, I'm going to move my fingers up just a little bit and move in a superior inferior direction. Again, move up a little bit, superior inferior direction, move up a little bit, and you're actually going to feel some tissue and kind of a hard surface of bone that feels like it's pointing at the sacrum. So right in this area, I believe I've found the ischial spine. So I'm going to leave these fingers here, and then I'm going to take the palm of my hand and go down along the lateral sacrum, like so. I'm going to move my fingertips to that location, and when I go down to the bottom inferior angle of the sacrum, I'm going to place my finger, and these two fingers should be approximately about an inch, inch and a half apart. If we get the camera directly over top of where I am, you will see that the sacrum one is slightly more medial and the ischial spine is more lateral, creating a slight oblique fiber direction of our ligament. I'm going to go directly in between the corner of the sacrum and the ischial spine, and I'm going to travel in a superior inferior direction to strum the sacrospinous ligament. Now this ligament is very deep and it does have sacrotuberous, and you're going through gluteals, so the chances of you feeling it directly are fairly low, but we're just kind of landmarking approximately where those were. One more time, going down along the lateral sacral edge to the inferior corner, finding ischial tuberosity, going up until you feel a piece of kind of bony material pointing at it, and again that should be about an inch, inch and a half apart depending on the body that you're working with. Go in the center and cross fiber, sacrospinous ligament, and that's going to conclude our palpation of ligaments of the pelvis. We're going to be palpating the ligaments of the knee, the ones that are palpable. So we are going to start just with the patella and talking about its connection to the tibial tuberosity. So first thing that we're going to discuss is quadriceps are attaching to the patella and all kind of surfaces all the way around it. So that would give you attachments on medial, superior, and lateral. And depending on what you kind of follow, that would mean that the quads tendon kind of finishes here, and then the apex of the patella and the bottom of it, we're going to have what is known as the ligament going down, patellar ligament, and that attaches into your tibial tuberosity of the tibia. So this structure here going from bone to bone, calling that a patellar ligament. I'm just going to mention, depending on your source and what you kind of follow, other people will call this patella a sesamoid bone that is encased in the quadriceps tendon, which basically then means that the quadriceps surround and attach to it, and ultimately the quads tendon is what is attaching to the tibial tuberosity. So again, just kind of check in with what you are using as a source to if you're calling this a patellar ligament or that it's just all quadriceps tendon into the tibial tuberosity. The second ligament we're going to go looking for is the MCL, otherwise known as medial collateral ligament, which is on the medial aspect of the knee. But what we need to do is to put the knee into a flexed position, because if you leave it in its extended position, you actually end up with the pes anserine muscles kind of covering over top of where this MCL is. So what I'm going to do is I'm going to place my knee up on the table, and I'm going to let the leg drop out a little bit into external rotation, and then I'm going to go searching for her femoral condyle, which is right in this area here, and I want the most lateral part of it called the epicondyle. The epicondyle is one of the attachments for the medial collateral ligament, otherwise known as tibial collateral of the knee, and that's going to cross the knee joint, which is basically right in this area right in here, and then it attaches onto the tibial condyle and actually extends down onto the shaft of the tibia. So one way, we're just going to look for a little visual. I'm going to grab her tibia and I'm actually going to rotate it a little bit. So by twisting the whole bone, you can actually start to see a little bit of that movement. So I can isolate exactly where the joint line is, which is right in here. And I can feel that moving back and forth. Or you can go underneath and make sure you push up the talus into the kind of talocrural joint. And I can again create a little bit of a rotational motion in here. So once I've identified where the joint line is and I have my bony landmarks, I'm going to kind of push back and forth and to feel for the rubbery structure, which is the medial collateral ligament. Take a little bit of caution directly in the joint line because your MCL is attached to your medial meniscus. So just caution about how much kind of back and forth friction you apply in this location right here. Now we're going to have to use a very similar principle for the lateral collateral ligament. So I'm bringing the leg back down, and if I went onto the side in this location and I just tried to palpate it in neutral, I would be trying to go through your iliotibial band and some of the tissue on the outside. So again, I need to have this in a flexed position. So I'm going to bring the knee up here. I'm going to look for now the outside of the knee on the femur. You can kind of see that as a pretty easy visual here. This is the epicondyle of the lateral femoral condyle. And then a similar, I'm going to be looking for the joint line, which I can kind of pinch the skin and show you exactly where that joint line is. Or I'm going to rotate the tibia again. So I'm just going to hold on to the tibia and create a little bit of motion so you can see exactly the femur moving without, the fibula and tibia moving without the femur moving. So that's going to help me identify where the joint line is. So this is called your lateral collateral, or otherwise known as fibular collateral, because the ligament structure is going down into the head of the fibula. kind of right in this area. So once I've found the joint line, I'm going to go in between the fibula and the lateral femoral condyle. And again, I'm going to feel for this rubbery structure right here on the outside of the knee. Doing a little bit of a cross fiber. So that is going to be the 3 kind of palpable ligaments of the knee that we're going to discuss. You do have 2 really important ones inside the knee, as your ACL and PCL, your cruciate ligaments. However, they are non-palpable, so you'll have to do some special testing to kind of see how they are feeling. We're going to be continuing our palpation of ligaments of the lower extremity by palpating the ankle ligaments. We are going to be starting on the lateral aspect, and we will not be covering every single ligament, but we're going to be starting with some of the ligaments that are prone to being injured. So an inversion ankle sprain where the foot is rolling in often injures ligaments on the outside of the ankle. So we're going to take a look at the 3 main fibular ligaments one at a time here, and I'm going to be moving the foot around and trying to do a little bit of assessment. So lateral malleolus of the fibula in between my finger and my thumb, and if you're dropping off anterior to that, we're finding the talus. So in between the fibula and the talus is a ligament known as the anterior talofibular ligament, ATFL. This is a really well-known ankle, one of the most common to get injured in the inversion ankle sprain. The foot typically ends up going into a plantar flexed and inverted position, starting to pull those bone structures apart until the ligament basically is damaged or snaps. So I'm going to put her in a neutral position for the ankle, try to go in between those 2, and then I am going to pull into a little plantar inversion to tighten them up as I go in a superior inferior direction. Now I'm going to move the foot so it goes flat on the table, just so you can kind of orient yourself here. So when we are having the foot flat, again, malleolus being here and the front of the talus being in here. So when I say superior inferior, I am meaning that the majority of the ligament fibers are running more like this. So to get a cross fiber, you will need to go more superior inferior with your fiber direction. So one more time, my thumb placement, this is the anterior talofibular ligament. We're going to bring our foot back down. Underneath the fibula in this location, going between fibula and calcaneus, is exactly that, the calcaneofibular ligament. This is, again, typically the second ligament to be injured on an inversion ankle sprain. And what happens is if the ankle is held more in a neutral flat plane, not going into inversion, but just straight over, almost more like a supinated position, you will start to feel a top band just below the lateral malleolus of the fibula, and that's connecting into the calcaneus right in here. So this is the calcaneofibular right in this location, and I can easily feel some tensile strength. It's lifting my finger up actually as I push her into inversion, so that's a good sign. So cross fibering calcaneofibular. And the third one is going to be extremely challenging to palpate, so it's going to be more of a in theory than it is going to be an obvious palp. It's going off the back side of the fibula, again towards the talus, which is deep and kind of posterior to it. So the Achilles tendon is going to be in our way, plus we're having fibularis longus and brevis going down in behind the lateral malleolus. Both of these structures are superficial, so I'm just going to be hooking my finger in behind the lateral malleolus and trying to feel the talus. So this is a posterior tibiofibular ligament. Instead of ATFL, we're getting PTFL. And I would need to bring the foot into some dorsiflexion and inversion to damage this ligament. So if you, let's say, stepped on somebody's foot that forced you into dorsiflexion and then you rolled off of them, that could potentially injure more the posterior aspect of this structure here. The last thing we're going to mention while we're on this side, you do have ligaments keeping your fibula and tibia together, which is, again, not going to be an easy structure because of where the Achilles tendon is, but ultimately you're going to be hooking in behind the fibula a little higher than talus, and this would be kind of a structure almost like the interosseous membrane, but there is ligaments holding these two bones together. So you're going to have some in the front and in the back that are preventing the bones from pulling apart or shifting too far anterior posterior. So if you've heard of a high ankle sprain, that traditionally means that these ligaments are getting torn, pulled apart, plus there's some damage going up the interosseous membrane between the tibia and fibula. So that's going to conclude our palpation of ligaments on the lateral side, and then we're going to come back for palpation on the medial side. All right, continuing with our ankle ligament palpation, we're now looking at the medial aspect of the ankle. I'm just going to roll the ankle a little bit out towards me. Good. So this is the medial malleolus of the tibia, and we're going to have a series of ligaments coming off the medial aspect, which are commonly known as the deltoid ligament. So I'm going to be naming them as the deltoid as a whole, but then individual ligaments, and there should typically be 4 of them included in that. So the first thing I'm going to do is again get a good idea of where this medial malleolus of the tibia is, and then I'm actually going to take my finger, and as if I'm heading towards the big toe, I'm going to run it inferior or distal, and then I'm going to come across quite a large bump that sticks up, and this is the navicular tuberosity. So on the medial aspect of the navicular, just distal to talus. So there's going to be a ligament. I'm just going to pull my 2 fingers apart here in this structure called tibio-navicular, and that is one ligament of this deltoid. It's going to be collectively the deltoid preventing somebody from going too far into eversion, and this is also kind of getting taught as I go further into plantar flexion. So I'm going to go right in between those structures, grab midfoot, pull her into eversion and a little bit into plantar, and then I'd be able to strum back and forth across the tibio-navicular. If you can kind of comprehend where tibio-navicular is, just anterior and a little bit deeper than that, this is the talus. So we have the navicular, and just proximal to that we have talus. So between, again, tibia and talus, this is the anterior tibio-talar ligament. Anterior tibio-talar, again, preventing a person from going into eversion plus plantar flexion is where you're going to feel this one get tensed up. So tibio-navicular, and just anterior to that, anterior tibio-talar. Then behind the tibio-navicular, a little bit more posterior, what I'm going to do is try to level the foot out a little bit, make it a little bit flatter by adding a little bit of dorsiflexion. And I'm going to find the inferior part of the medial malleolus, and I'm going to head inferior towards the plantar side of the foot until I drop off of bony structure into soft tissue. So we have very obvious bone underneath it. It's going to be a little bit of talus, and then the last part of bone before I drop off into soft tissue, this is a part of your calcaneus known as the sustentaculum tali. So between the inferior medial malleolus and the sustentaculum tali is that tibiocalcaneal ligament. So I'm going to go in between those 2 bones, and I'm going to go more into a pure eversion. So I'm going to take the heel and just pull it straight over, and that's going to tighten up underneath there. Now we are getting into kind of this realm where the tendons going behind your medial malleolus are going to start to cross over. So you might start to feel a little bit of tibialis posterior and flexor digitorum longus in here, but that's why I'm trying to leave kind of where the distal part is, and definitely no muscle activation, and just feel a little bit deeper into the bone structure. So this is tibiocalcaneal. And as I just explained, because these tendons are crossing over, the final ligament of this deltoid group is going to be very hard to feel. And just like on the lateral aspect, we're going to hook in behind the malleolus. Use my other hand here. And this is going between the talus and the tibia again. So instead of anterior tibio-talar, we have a posterior tibio-talar. So as I force the foot into some dorsiflexion and eversion, This is, in theory, tightening up this posterior tibio-talar ligament, which is not going to be easy to palpate because of tibialis posterior and flexor digitorum longus crossing over top of it. The final ligament that we're going to discuss on the medial aspect of the foot today is going to be known as your spring ligament. However, it has a secondary name between the two bones that it attaches to, and that is calcaneonavicular. First thing I'm going to do, again, similarly to what it was just done, I'm going to fall down so I can find the sustentaculum patella, and then I'm going to head distal or even off the malleolus distal until I come across the navicular tuberosity. So in between these two bones is your spring ligament. It's on kind of more that plantar aspect. So I'm going to hook underneath the bones and I'm going to kind of strum superior inferior more than proximal distal. And it gets its name spring ligament as you weight bear or load bear on the foot. It's going to lengthen the foot out, which is then going to spread these bones apart. So if we collapse the foot in, that kind of shortens it, but as I weight bear, especially on this medial aspect on the big toe, it's going to create some length. So if you want to, you can slacken it, put your finger into it, and then start to lengthen that out, and it'll get tighter underneath. So again, one more time, this is between calcaneus and navicular, calcaneonavicular ligament, otherwise known as the spring ligament. So that's not every ligament of the ankle and foot complex, but it is the main ones, and that's what we're going to be discussing in this video.